2021 and our quarterly webinar series presented by the Business Innovations Department at Androscoggin Home Healthcare and Hospice. My name is Jillian Netherland, and I am a member of Androscoggin's business development team, along with Lisa Kaye, Sarah Decato, and Sean Hackett. Depending where you're located, you may know one or two or all of us. While our webinar series is new, our face in the community is not. Androscoggin was founded locally in 1966 and today is the largest not-for-profit home health and hospice agency in Maine, serving nearly 450 partner affiliations in more than 185 communities. Because of our nonprofit status, we are able to provide more than $1 million in care each year. We are proud to offer a comprehensive suite of services, including home health care, hospice, and palliative care. What this means to our partners is that we are able to provide a seamless continuum of care for your patients as their needs change. These webinars are to serve as a helpful educational resource during this time of being unable to connect in person as we once did. Today's topic is telehealth and remote patient monitoring, chosen due to the increased need in the wake of the COVID-19 pandemic. Our goal today is to show you what we are doing and how we can help you care for your patients and residents during this new normal we are all doing our best to navigate together. Please know that this webinar is for you, our partners. We encourage you to ask questions as you have them through the chat box so we can be sure to address them and get you the answers you need. Here to discuss the ins and outs of the telehealth world are our subject matter experts, Melinda Lovering and Shane Lavasser. As Androscoggin's manager of virtual health, Mel brings more than 15 years experience in healthcare. In 2017, Mel was selected to spearhead the implementation and growth of telehealth services for St. Mary's parent organization, Covenant Health. Since joining us at Androscoggin, Mel has been focusing her efforts on expanding the organization's robust remote patient monitoring program, ensuring that virtual care is integrated into the daily delivery of quality healthcare. Mel also represents Androscoggin at the state level by participating on Maine's Telehealth and Telemonitoring Advisory Committee, which focuses on the long-term sustainability of telehealth policies and reimbursement. Shane Lavasser, Androscoggin's clinical coordinator of telehealth services, has been master of the telehealth game long before the days of COVID-19. Since 2006, Shane has been instrumental in building and expanding Androscoggin's home telemonitoring services by partnering with hospitals and skilled nursing facilities to care for patients at higher risk for complications and re-hospitalization post-discharge. Now as the organization's telehealth clinical coordinator, Shane oversees the daily use of more than 450 monitors in patient homes throughout the Androscoggin service area. So now without further ado, I will turn the webinar over to Mel.
Thank you, Jillian. Thanks for that great introduction. And I want to just thank everybody out there today who's taking time out of their busy schedules to join this webinar and hopefully to learn some things today about our program here at Androscoggin Home Healthcare and Hospice. I think it's worth noting for me on a personal level that I'm relatively new to the team. I just came to Androscoggin 10 short months ago. And what a year it's been. I joined the organization coming from a health system environment that actually had a contract with services for telehealth with Androscoggin. So I was very aware of what the agency was doing in the community. And I was so impressed by the dedication from senior leadership, from our CEO, our chief clinical officer, our chief financial officer. There is kind of that top-down buy-in. And what you're going to hear today is that there's over 20 years of experience at this organization with virtual health. So long before COVID-19 appeared. And it's just a really exciting time for our program and also to share with you our history and where we hope to go in the future. So to kick us off, we just want to do a quick poll question. We just want to get a sense of who's out there today listening and what types of organizations you all represent. So if you can just choose the answer that most aligns with you, that would be great. We'll take a minute to just get the results back. Just let me know when the poll closes. Okay, it looks like we have a lot of health system representation and skilled care. It's interesting. We were really, as we started to think about the content today, we were hoping that we would have a good smattering of folks from different organizations. So this is very helpful for us to kind of drive the discussion. And again, really encourage you to type in your questions along the way so we can answer them. So I'm going to start with our objectives. Just kind of a loose agenda that we put together again as we wanted to think about things to really define telehealth. I think that term differentiating telehealth versus remote patient monitoring. Over the past year, I think it's almost gotten confusing as to what does telehealth mean, and again, how does it differ from the program that we've developed here at Androscoggin for home monitoring. We'll provide an overview specifically of our program here, take you back again 20 years ago when Shane first started here, and how he really worked to develop our infrastructure and to really get us to the point we are today, where we're able to partner in the community with lots of different referral sources. And then we'll dive into some clinical outcomes, experience that we have shown over time. Primarily, you'll see references to things like readmission rates, high cost care avoidance, such as emergency department visits, and also our patient satisfaction results. And I think the most important thing that we're going to get into today, again, is really how our agency, because we are, I'd say, kind of small and nimble, even though we are the largest independent home health care hospice agency in the state, we have the ability to really adapt to our partner needs, and we'll give you some good examples of that today. So again, let's start out just by defining more what we're talking about today, and again, that buzzword telehealth. I think we all can think of examples, especially over the last year. I know, being in the health system environment, when COVID first started, the first thing was thinking about how do we keep connected with our patients. So a lot of you might think of telehealth as that video visit that you might be doing with your physician because you couldn't get into the office to see them. So certainly that live audio video modality. Also, it can be as simple as using a patient portal just to send a communication or a secure email to your physician or a care team member. And it could be using a health app on your phone. I think a lot of facilities got creative, again, as a result of the pandemic, and used things like iPads and laptops to connect family members who couldn't see patients in the hospital or residents in a facility, their family members. So again, telehealth is really a lot of different ways of sharing health-related services and information. And remote patient monitoring is one example of that, which we'll define for you now. So remote patient monitoring, or RPM, is the process of collecting and transmitting patient health data. And a lot of times that's happening in the home setting. So for instance, the way we typically start with a patient is they're coming out of a facility, they're being discharged in a lot of cases. Maybe they've been hospitalized with an exacerbation of their COPD or heart failure patient. And they're being discharged with a lot of instructions, maybe new medications, and a monitor is ordered for them to have brought to their home. And it will also have accompanying peripheral devices, depending on what they're trying to manage. So it could be a blood pressure cuff, pulse oximeter, a scale for weights. These will connect and allow data to be transmitted electronically to a care team that's in another setting. So in our case, again, that's our telehealth nurses that are here in the office or right now working remote, but they're getting this data every day and responding to it in real time. So as they start to see trends in data or something that's not looking right, they'll do direct outreach to a patient by phone or video, and they'll be able to kind of drill down and see what's happening in the home. Has the patient taken their medication? Have they done it correctly? What have they had to eat or drink? So all of these types of interactions allows us to track health data in real time and again, contribute to the reduction in potential for going to the emergency department or having a high cost hospital readmission. So now we have a poll question. Again, another question just to get a better sense of what you all have experienced and your familiarity with RPM. Maybe some of you were using it before COVID-19. We'd love to hear that. Or maybe you put something in place as a result of the pandemic. And also, maybe you're just contemplating use or thinking about it at this point. But if you could just choose the answer that best reflects where you are today, and we'll wait for those answers to come back. All right. And I think this is interesting because I would guess that a lot more people have used the, when we say telehealth, the video visits or communication technology. But I think that remote patient monitoring is something that this doesn't surprise me. A lot of people are contemplating now, and we're hearing a lot more in the news about care at home and what that can look like. So I would guess that these percentages will change if we were to come back in another 6 months or so. But this is exciting to me that maybe you haven't used RPM but are thinking about it. So that's great to see. And think about where we were a year ago. Again, having worked in the virtual health space pre-COVID and working for a health system, I can tell you we talked a lot about using it. But I'd say we were dabbling. We had some really strong programs, but the day-to-day utilization, especially in the primary care setting, just really was non-existent. And that's what you can see in this graph when you think of 2019, minimal, if any, utilization of telehealth resources. And this is specific to the Northeast region, but you see how quickly that changed in 2020. And a lot of that was because of what was happening with COVID, which in the graph with the green, and I'll call it brown, could be my color blindness, but you see the big spike between March and April, which we all know it was kind of like the wild, wild west. It was just everybody had to kind of pivot and react and respond to the crisis that was, we got to see our patients and people in their homes to keep them safe. So this graph reflects that, but also I think the difference between the green and the brown or maroon, those reflect health disparities that are still present and very real. We know that our rural setting patients have barriers with internet access. A lot of them don't have computers. We've been fortunate that a lot of payers have allowed for audio only telehealth to happen. But as an agency that serves a lot of rural communities, it's just so important that this is addressed. The good news is there's a lot of legislation out there now to help confront things like in a state like Maine, the broadband infrastructure. So it'll be interesting to see if we can close this gap as time goes on. And we are certainly committed to that here at Androscoggin. You will hear later from Shane about some of our technology and how we've chosen certain technology to kind of get around some of the barriers that exist with internet. So now I'm going to turn it over to my colleague, Shane, who's our clinical coordinator. I joke with Shane that I call him our founding father. He basically started this program from the ground up when he joined the agency, and he's going to talk about how he really worked not only on the technology side, but as someone with a clinical background, how he worked with staff to really get that buy-in and get us to where we are today.
Thank you very much, Mel. Thank you, everyone, for joining us today. I would encourage you to use the chat box If you have any questions, we will try to answer those questions at the end. But Androscoggin has a long history of remote patient monitoring and telehealth. Androscoggin started services with a very modest program. They purchased 25 units back in 2000. At the time, they were using these units exclusively for patients receiving skilled home care. Over the years, we've updated our equipment and increased our inventory, but the technology has changed tremendously. I joined the organization in 2006, initially as a field nurse, and then shortly after that, as one of the staff development educators doing orientation with staff. The technology back then, the patient would be able to test their vital signs, and all of the information, the data, biometrics would go through the telephone line that was in the patient's home. So when we'd place a monitor in the home, we would have to locate a unused phone jack, often moving furniture, crawling under beds, whatever the case may be. If they didn't have a spare, we'd have to use a splitter and a filter and plug it into their phone, and they couldn't use their phone while it was transmitting the data. Even with those technical difficulties, I realized early on the benefit of monitoring can really fill the coverage and care between visits. I started going to team meetings, putting signs up on walls, doing chart audits, sharing success stories that we were having in our program with the field clinicians to really generate that buy-in and get their understanding of why and how it benefits our patients. In 2011, we received a matching grant. We continued to increase our numbers. In 2012, we were up to 250. Right around 2014, 2015, our vital sign measurements started to interface with our electronic health records, meaning all of our field staff, physical therapists, and social workers and nurses and stuff could see those vital signs as part of their chart. Numbers quickly increased in installations. By 2016, we had over 1,700 installs. In 2020, we began partnering with Health Recovery Solutions, increasing our total inventory to 450 units. We now utilize telehealth amongst all of our service lines, all programs. We're on track to install over 3,000 monitors in 2021. We have a total count of 580 units now. We've increased our telehealth line to include a mobile application that can be installed on patients' mobile devices, iPads, or cellular phones. We continue to grow our program with a goal of serving more patients. Our patients embrace telehealth and remote patient monitoring as part of the plan of care. The volume of patients who've used telehealth has grown 65% between 2015 and 2019. We continue to scale and invest in staffing and technologies to continue access to services. Back in the early days, it was just me. I would do the interaction with the patients, facts and trends, sometimes doing installs, following up with physicians. Now we understand we're a lot larger and we're across the board in all of our programs. Our infrastructure is essential in maintaining the health of our patients in the communities that we serve. Nancy Wright provides the clinical oversight. She is our nurse practitioner. Mel is the department manager. I am the clinical coordinator. I do a lot of the trainings with staff, as well as providers out in the community, as well as patients. We have a telehealth technician that does the installations out of our Lewiston office, and she assigns the equipment to all of our patients that are being onboarded. We have 2 registered nurses, and we actually just listed a position for a 3rd registered nurse to be doing our telehealth day-to-day interactions with our patients, following up with physicians, facts and trends over as needed. We also strategically have placed monitors in all of our different locations for a quicker turn time on installation. Our partnership with Health Recovery Solutions has allowed us to have real-time communication with our patients, whether that's through HIPAA-compliant video, direct texting, or telephonically. With biometric and medication reminders, we do daily performance tracking, health coaching, dietary guidance based on conditions and diagnoses, all being provided by registered nurses out of our telehealth department, as well as disease-specific educational videos with post-test. Our equipment, as I said, has changed over the years of being in the industry. Again, our patients do not need to have a computer in their home. They do not need to have Wi-Fi. Our technician will bring the equipment already programmed to that patient upon arrival. We open the box, turn it on, and it's ready to go. It has a 4G built-in data internally, so there's no need for Wi-Fi or a computer. Our telehealth technician will demonstrate how to use the equipment. Again, the equipment is specific to the plan of care. So not all biometrics are needed for all patients. It's what is most important and what we're trying to track for that patient. After demonstrating use of the equipment, we have the patient return demonstration with the guidance of our technician in the home. And then we call our telehealth department to verify it transmitted and have our registered nurse connect with that patient at that time, look at the vital signs, and set perimeters based on the individual's vital signs. Again, all of the care plans are customized specifically to our patients. I'd like to share a case study with you. This was a 77-year-old patient who lived alone, showed up to a PCP appointment, and the blood pressure was elevated. This physician was well aware of our telehealth program, asked us if we could put a monitor in this patient to better determine if this patient was really hypertensive, or was it just the anxiety of going into an office visit for white coat syndrome, or was it the exertional effort that took place having to go from the parking lot to the appointment. So we were able to place the equipment in the home, have the patient test in the convenience of her own home on the same equipment at the same time of day using the same technique. It's very compelling to look at those vital sign trends over several days and make a determination if they have hypertension or not, or how they're feeling. We notified the primary care physician, we faxed trends over to them, and they did add lisinopril for this patient because it was indeed truly higher than they wanted it to be at. The patient's blood pressure improved, and because of this, the patient was never seen in the emergency room or had to go to the hospital for an admission. We know that going to the emergency department or being admitted to the hospital can have physical and financial implications for our patients.
So now we're going to get into some of our outcomes. I think we want to share the value proposition that we've experienced with RPM and what we've seen for our patients. And can't really talk about the solution without framing up the problem, but I'm sure most of you are aware that penalties for excess readmissions, and this slide is specific to Maine organizations, so this is looking at Maine hospitals as well as nursing facilities, that over 60% in most cases, in 2021 they're forecasting up to 71% of Maine hospitals will experience excess readmission penalties, and totaling up $600,000 annually. In the past year, knowing what COVID-19 has done for just finances and budgets for healthcare organizations, this is something that probably is keeping folks up at night, and we know that. This has been a long-standing issue, and that is exactly why remote patient monitoring has been looked at as a potential tool and resource for organizations to help make a dent in these types of numbers. So at Androscoggin, we're really working on our policy, moving it to an opt-out, essentially looking at that all of our patients coming on for being referred for home health services would be eligible to have home monitoring. When you're looking at the slide, you can see the most common primary diagnoses that are coming to us. So those circulatory system diseases such as heart failure, respiratory. I think every organization knows that those with heart failure, COPD, those are the patients that are highly at risk for going back and forth to the hospital. And we're fortunate because we can look at that home health population with our platform for telehealth and our electronic health record, which are integrated, and also our strategic health planning data platform. We can look specifically at our 30-day readmission rates for our telehealth users versus those who don't have a monitor. And you'll see that column that's highlighted in the light blue, the readmission, the 30-day readmission rate performance for telehealth users, and in some cases significantly lower than the overall population. So this for us really reassures us that we're doing the right thing. That leap of faith, again, 20 years ago of starting home monitoring. Now we really want to be data driven and show what this type of program can do for our patients as well as the patients, we're really all collectively trying to better manage. So when patients don't qualify for home health services or skilled nursing, we've worked with a few local health systems to develop a contracted partnership for a way to refer patients, what we call telehealth only services. So just because they don't qualify for skilled nursing doesn't mean these patients coming out of the hospital at discharge don't need support. Think of all the information that they are getting when they're leaving of medications, dietary restrictions maybe, all these things related to their care. And having another set of eyes on them, I think our partners have realized we want to support them in a way that, really gives them more and feel empowered to better care for themselves and keep them out of the hospital. So we have served over 1,400 patients in this capacity since 2014, again, with that primary goal of reducing 30-day readmission rates. And these are some of the results we've seen. Again, year over year since 2016, when we really were trying to develop these referral partnerships, the all-cause 30-day readmission rates, really impressive, down as low as 2.5% in 2019, and an average annual rate of 3.8%. So we really believe if you go back to that example Shane gave of that hypertensive patient, that we have a lot of referrals from primary care that just says, I want the patient to get a better handle on this and understand their trends. As simple as that, we're just showing that this is keeping them from escalating to a point where they might go to the ED or might, unfortunately have a stroke event. So again, these numbers are very impactful over time. So I think one of the outcomes we're most proud of here is just we know our patients really love this service. This reflects a survey. We work with our vendor to survey our patients from time to time, and they let us know that because of the service, they feel more connected to their care team, they feel supported, and I think most telling is that 92% of users would recommend the telehealth program to others, whether that's a friend or a family member. And these are patients that go up to, our telehealth technician told me this morning she installed a monitor, 88-year-old, very tech savvy, and was really excited. They did a video visit together with our nurse, and it's amazing what this technology can do for them. So these numbers really are a testament to the satisfaction levels that patients have when they're using RPM. So now we have a very specific example of a partnership that resulted really as a result of the pandemic and COVID-19. I think we all know the consequences that congregate settings and senior care facilities have had dealing with the virus and how hard they were hit. You have a few positive cases and it can really run rampant, not only for residents, but for staff as well. So right around New Year's, Androscoggin was approached by a referral partner who knew of all of our services, but as a result of some positive cases that were coming in, they approached us about trying to support them to really get things under control early. They knew we had telehealth and the ability to scale up very rapidly. We deployed over 70 tablets using the Health Recovery Solutions mobile application. We were able to put these devices in resident rooms where the staff could take vitals daily. We were working with a nurse practitioner in the local community who was able to monitor the care and use these readings every day to really direct traffic and to know who she had to have a video visit with, who might need to be going to the hospital. They also had a great community paramedicine team that would go in and do in-person assessments if that was needed. And also we could incorporate our staff at Androscoggin, who if they had to go in and work with the patient, they could as well. And we also use the technology to have care planning discussions and goals of care, so that if the continuum needed to move to a palliative situation or a hospice situation. I can't say enough of how this partnership really, for me, summed up the collective good of what everyone has been trying to do and how technology helped to make this happen. So now you're going to hear from two folks that were involved in this project with us. The first is Jill Soroy, who is from the Woodland Senior Care Facility, and the second is Deb Birchfield, the nurse practitioner from Franklin Health Primary Care Network.
Telehealth gave the providers, immediate access to health monitoring data being measured by our personnel, and it allowed them to very quickly identify residents who were in need of, medical intervention and, prevent hospitalizations.
So being remote, but being able to have the tablets there and the telehealth and the remote monitoring there in the facility was crucial to being able to manage these folks. Me working at other facilities and managing primary care, it'd be very hard for me to put myself at risk coming into that facility and managing those folks. But it was easier to do knowing that I had data that I could look at every morning, data that I could look at around noontime, and then if something came up, I could log in and see what was going on. I also was able to access the tablets in the patient's room for the face-to-face visits, and then the main two tablets where the staff could do walking rounds with me if we needed to, just so, they know the residents and they know what's going on with them. Oftentimes it doesn't show in the vital signs, but they were able to carry those tablets around so we could do face-to-face visits at a designated time during the day as well.
The outcomes, I think, for all of us were, we were able to treat residents where they were. We prevented unnecessary hospitalizations. Very few residents were admitted to the hospital during that COVID outbreak. I think it made our staff feel more secure that the provider was looking at that data on a regular basis. And I think the provider probably felt the same way.
Our goal in the very beginning was, of course, to have positive patient outcomes, be able to keep the patients in the facility and shield the ER and the hospital and putting anybody more at risk. So being able to use the telehealth equipment was crucial to being able to do that. And at the same time, getting that clinical picture and being able to document what's going on with the patient, and being able to just try to intervene as quick as we can as soon as they start developing symptoms.
you know, as far as words of wisdom, I think just do it. It's a tremendous, tremendous benefit. There really is no downside. It's all up. It's just wonderful.
Well, I can't tell you how much that partnership meant to me. It was an intense couple of months. It really was a project that went from New Year's Day to probably the middle of February. We all got to know each other very well. But to me, this is why we do the work. This is why we do try to deliver these types of outcomes together. And when you can have that type of partnership come together so quickly and see it kind of evolve and have wonderful outcomes. I think the other piece that we heard back from was that families really appreciated the work that these organizations did. They really appreciated the fact they put so many resources in place for their loved ones in a very tough time. So anyway, it was a pleasure to be able to share that with you today, and we're really thankful for everyone who was involved with that. So we couldn't escape today's conversation without talking about dollars and cents. And I just want to share a little bit about the economic model, or sort of the reimbursement landscape right now for RPM. The good news is that Medicare, which for us anyway, that's usually a large payer source, they've embraced RPM. Pre-pandemic, 2018, they created the first codes for this type of work, and they've continued to evolve and expand. So there are 2021 physician fee schedules just came out and were finalized for RPM, and they are they basically offer codes for different sets of information. So there are codes available for the initial setup of the equipment and education of the patient in the home. There is a monthly code for just the supply and transmission of data that happens from the device to the care team. And then there are codes for clinical time, 20 minutes of clinical time, the first 20 minutes and additional 20 minutes. But that does have to include real-time communication, audio, visual, or video components. And it does also include charting, documentation, care plan management. And I would just say this could be a whole nother webinar topic, but if you have questions specific to billing and want to learn more about those opportunities, I would encourage you to reach out to your business development team or your provider relations folks, and we're happy to have those conversations with you and share what we've learned in our time learning how to bill. The other thing is that state Medicare, Maine Care will pay for RPM. At this time, it is only for home health agencies to be able to bill that. So patients do have to be on home health services for Maine Care. So now we have one last poll question for you as we start to wrap up, and hopefully there'll be some questions. But we certainly hope that the content today met, the objectives that we set out in the beginning. We'd love to know what more you might like to learn about. For future webinars, or also just maybe talking again to your business development contacts and letting them know what we could maybe follow up with you about when time allows. So if you don't mind taking a moment to check all that apply there. And I'll just make another plug to type in any questions that you guys might have. And as we wrap up, before we do, I'm going to have Shane just outline some of our current projects, things that we're working on as we move towards the future.
Thanks, Mel. So Andro Connects is a virtual volunteer program. We just launched it earlier this month, very exciting. This is really to help patients. We realize the social isolation concerns that are going on, especially in the rural locations. Our device is a 10-inch tablet. that we're able to pair up patients who want to, regardless of the program, patients that want to have a volunteer remotely, they're able to, and we'll meet with our manager of the volunteer department and pair up someone with similar interests, and they can conduct visits with them. Also, we're working towards ACHC telehealth distinction, which is based on nationally recognized standards for optimum care, safety, and privacy, better prepares organizations for regulatory requirements. And we're always looking for increased partnership opportunities, whether that be primary care, insurance providers, skilled facilities, for any of our programs that were mentioned, whether it's skilled care, palliative, hospice, remote patient monitoring, community care team, and the growth. We're committed to growth. We're continuing to grow, as I said earlier, and we continue to invest in the latest technologies to provide the best care for our patients in the comfort of their own home.
So Jillian, we'll turn it over to you if you want to let people know how to connect with your team and open it up to questions.
Absolutely. So it looks like we do have a few questions in the question box. The first one here is, what is the impetus to begin telemonitoring? Is it only for patients who are eligible for home health? Monitoring end once the patient is discharged from home health. So they're asking what would be a starting point for someone to get on telehealth, and when would the monitoring end?
So Shane, I'll start with one component of that, and then I'll turn it over to you. Basically, I'm going to just frame up from a payer source in terms of if you are looking for, if certainly a patient is eligible for, if they are referred to Androscoggin for home health services, our policy is that, you know, we could place a monitor with them, or the referring physician could order that service as part of the care plan. So it can either be started with the physician referring, or it could happen. Sometimes our nurses will visit with the patient, and because we have the technology, they'll identify a need and that monitor could be placed. In terms of how payers look at it, so Medicare, for just a patient who doesn't qualify for home health, but a physician might want to refer them to us to have their blood pressure tracked. That is something that can be billed for. Medicare doesn't say that it has to be a particular disease state. It just has to be a chronic illness, really in the clinician's judgment, that needs to be tracked. The patient might be more at risk for re-hospitalization or increased ED utilization. So the eligibility is pretty open, and we do accept referrals for home monitoring outside of home health services. Shane, do you have anything to add about that clinically?
No, I was just going to kind of just echo what you were saying, Mel, that, you know, we have been receiving referrals for any of our programs, and they will get a telehealth unit, but also for those patients that don't necessarily qualify for home care or necessarily want home care, they can also, potentially qualify for remote patient monitoring.
And we actually just had another question come in. Is remote patient monitoring billing for a given day, or is it affected by prescription, provider, patient, or home visit?
Okay, I will try to, if I'm interpreting the question correctly, and they can type in if I'm not, but to bill, let's say it's Medicare, there are some components that have to be met in terms of getting a claim out the door. So first of all, it can only be billed by a Medicare B service provider. So right now, remote patient monitoring is not covered by Medicare under a home health benefit. So it has to go through a Medicare B clinician to order it. It does need to be referred to as part of a plan of care. It can be right now under the public health emergency, a minimum of 2 days of health data needs to be transmitted, and that is specific for patients with a COVID-19 either they're a person under suspicion of having it or they've been a confirmed case. Typically, it's 16 days of monitoring that has to be completed in a 30-day period. So let's just say a patient can't just get a monitor and have it sit there and not utilize it. They do have to transmit data 16 days out of the month. And for the codes related to clinical time, that does have to be documented, how that time was spent every month to bill. So I hope I touched on that. I think I answered what you were, if not, please type in and I'll try to clarify.
So far, so good. I'll let you know if anything else comes in. We did have a few questions that were submitted to us ahead of time. One of those is, can patients obtain this on their own?
Do you want to answer that, Mel? Or they can, yes, absolutely. I would encourage, anybody to reach out to our business development team, or myself or Mel specifically. We could discuss the specifics with the individual, but no, they don't need to be part of the plan of care. They can request that. Has to be a doctor, usually makes the referral for us and has to be on board with that, but we do have our nurse practitioner that does the oversight.
Okay. Another question was, how and when is this information relayed to the primary care provider?
Immediately. I mean, initially upon entering the program, we notify the physicians involved that they're part of that. We do ask if they would like trends sent to them automatically. Most don't want them unless there's a concern, but we do offer that. Also, we can provide data or trends for upcoming appointments with either PCPs or specialists. We do that quite frequently. We'll get a call saying, Mrs. Johnson's going to be going to the cardiologist. Can we have the last 14-day trend faxed over? And I'll be there waiting for them at their visit.
All right. And kind of going along with that, we have, how long does the device stay in the home?
It really varies from case to case. If there's still a need and we're still a reason for us to have that in there, then it's appropriate for them. In some cases, like Mel said, if patients stray off and aren't using it, but they just kind of want to have it, then we request. And we don't want it to be a crutch. We want it to be a tool for them to better understand what's going on with their care, and to be able to monitor them more closely.
And the last one that we have right now is a little bit of a throwback to some old school commercials, if anyone else picks up on that. But is this considered a lifeline resource?
It is not. I mean, have we had success and saved lives? Absolutely. And we have success stories practically daily, honestly. But it's not an emergency device. It's a tool for us to be able to monitor trends, to better manage medications and care. But sometimes we have caught things that were urgent, yes.
Wonderful. We don't have any more questions right now. That covers all of them. Shane, Mel, is there anything you'd like to add while we give everyone just a minute or two to see if there's any last minute questions at this time?
One thing I just want to emphasize, and I may have said it earlier, it's not one size fits all. We really customize what peripherals devices are being offered for patients if they have the ability to utilize them. For example, we don't need to have a scale if the patient is really unsteady on her feet, things of that nature. We have the ability to have there's a camera built onto the tablet, so we can do incision line imaging, as well as wound imaging, consulting with our certified wound nurse. We also collaborate with our certified diabetic educator for any of our diabetics that we're monitoring their blood sugars. So they're looped in, and we can do like conference calls up to 5 different people with our patient's device.
And we did have one last question roll in, and I just have to say, I really love how this one is worded. How do you promote patients' ownership of their health?
That's a good question. I think that our nurses do a really good job, and I'll have Shane chime in on this too, because he is a clinician and has done a lot of this work. But I think that our nurses really, they develop a rapport. They get to know the patients, I think, because not only are they just, looking at data coming in, but they are talking to them on a regular basis. And that outreach, even if they don't hear from them, that triggers something to say, hey, we haven't heard from you in a while. Just how are things going? They get to know their habits, oh, so-and-so, they do their testing at 10 o'clock every day. They know what they have for breakfast. They know the critical questions to ask as well about their patterns, and they really encourage the patient to make the connection between the patterns and what leads to the result. So I have learned so much just being around them. I am not clinical in background, but I have listened to some of the interactions and learned from them. So Shane, I don't know if you have other observations, but that's what I've learned.
Yeah, I mean, I definitely agree with what you were saying, Mel. I feel by monitoring patients' vital signs, trends on a daily basis, and having video conference calls with them and telephone calls regularly, we actually have a better handle on how that patient's doing. As Mel said, when I first started, or as I said, when I first started with the organization, I was in the field and seeing patients, and often you'd see a patient one time a week or 2 times a week. We're seeing this data much more regularly, so we do form a relationship with that patient, that we have a better understanding of where they're at and what they're doing. A lot of times patients are much too sick in the hospital for education, and the average length of stay is always being reduced, and they don't have the time to do a lot of that education. That's what we're here for, to really make sure we can go at that individual's pace in their own time frame, as opposed to you're being discharged right now and we need to give you some education. So I know that we want to try to continue the education, so it's provided at their own pace in their own home.
And another one that we had come in: has a community partnership been created with Delta Ambulance for Kennebec County?
Not for telehealth, not specifically that I know about, and I will be transparent. Our agency is always talking to lots of people, and I would have to say, I'd have to just make sure that maybe there could be something that I'm not aware of. But in terms of a telehealth partnership, I don't know if that group is involved in the community paramedicine or the ET3 telehealth. I know a lot of ambulance services did reach out to apply for that, and I think like the group that we were working with might have been put into that. But I think that there's no question that our agency sees EMS and ambulance services as a critical partnership and something that is evolving and changing. I think that whole care in place, not taking everyone to the hospital, you're going to see a lot more of that. And if we don't have a partnership and someone's out there, call us. We just love to hear from people and consider any of the options. So we love to hear what other people are thinking of doing. And if we can help, we would love to.
Perfect. Well, I just want to thank everyone for taking the time to join us today. I know that time is something none of us have abundance of, and that has been even more true over this past year. If you're like me and you think of questions after the fact, I know I always do once something ends and I'm not speaking with the people anymore. Please reach out to Sean, Sarah, Lisa, or myself if you have a relationship with us. You're also always welcome to call the Androscoggin main line or our info email, info@androscoggin.org. Also, a recording of this webinar will be sent out to everyone who registered for today, so you will have access to everything we discussed, and you will be able to see the slide at the end that has all of our contact info there. Please, we mean it, do not be a stranger. We want to talk to you, and we want to help you help your patients.
Thank you, everyone.
Thank you, everyone.
Have a great day.